occurring in Rockville Center, and I'd like to bring attention to that fact right here, because as a native of Rockville Center and also as someone that lives in Garden City, it amazes me how many people don't know that we're in Rockville Center. So that's my 20-second plug. I am going to talk to you about BRCA-related breast cancer and some new treatments and developments. I'd like to know who my audience is, so if I could just see by a show of hands, any doctors, nurses, medical people in the audience? Okay. Anybody who's had any other involvement with breast cancer? Depth of information? Okay, good. So I hopefully will be not too basic, but yet not too advanced. So I'm going to start at the beginning, very quickly, go through a quick review for you. In the beginning, we have a cell, and in the middle of the cell, we have the nucleus, and in the nucleus, we have DNA, which are part of the chromosomes. The DNA codes for protein. Okay, so in the DNA, when we're dividing our cells in mitosis, we are dividing the DNA, it duplicates itself, it spreads itself apart in anaphase, and then breaks into two cells in telophase. This whole process is a very intricate mechanism that requires multiple hundreds of thousands of proteins and DNA genes to be working in synchrony. So here's just a picture of some chromosomes. And this is an idea of the sample human genome. As you can see, we have 22 chromosomes with an X and a Y sex chromosomes. Well, some of them. In the DNA itself, as I had said, the mRNA from the DNA is copied into RNA, is then made into a protein, and the proteins are the functional portions of the cell. Everybody have that so far? Okay. So, moving on. Oncogenes are basically when the cell's mutations within these genes go awry. And these oncogenes can accelerate cell growth and division. There are also tumor suppressor genes, which I'm going to talk about as well. So this is just the two hits hypothesis for cancer in general. The idea is that people can be born with a germline mutation, something that you get from your parents. And then there's also somatic mutation, something that you can actually grow into and develop. So what causes somatic mutations, for example? DNA damage is caused by genetics, environment, as well as just chance. With all the divisions of our cells, it's amazing that we're not just walking tumors, to be honest with you. So what are our lifestyle factors? Unfortunately, half of these here I can say most people have a problem with. Exercise every day, eating a low-fat, low-carbohydrate diet, not drinking coffee, don't drink alcohol, don't smoke. Everybody with me? Okay. Okay, so basically I want to talk about how the fact that cancer tends to involve multiple mutations. No tumor develops out of one or two mutations of the cell. There's always multiple hits, so to speak, to the DNA. The cells will become progressively more advanced and abnormal. So for example, in breast cancer, we have typical hyperplasia, atypical hyperplasia, overgrowth of the cells, becomes an in situ, a cancer that doesn't grow but overgrows itself. And then invasive cancer, a cancer that has learned how to grow and move and spread outside of its normal environment. So, what is a BRCA mutation? Basically, it's a change in the DNA in the area of the breast cancer genes. This increases your risk of developing cancer. These BRCA genes code for tumor suppressor proteins. These are, let me explain this clearly, when they're functional, they can repair the damaged DNA. So you get a damage from UV light, the BRCA gene, when it's working, will fix that DNA. When the BRCA is mutated, the repair mechanism is non-functional and cancer can develop. That's a one hit. That's obviously not the whole story. So here are the two BRCA genes. One's on chromosome 17, and 2 is on chromosome 13. So that's all very interesting, but why do we care? Essentially, why BRCA is so important is not just because of the risk of hereditary cancer, which only comprises about 5 to 10% of all breast cancer patients. The sporadic cancer patients, 90%, 33% of these have BRCA1 decreased expression. So BRCA mutations from germline, in other words, a family trait, is also seen sporadically occurring. So this has more of a role than just hereditary cancers, and that's important for our development. So the association between BRCA1 and what we call triple-negative breast cancer is a very important one that I'm going to explain. So let's start with what is triple-negative breast cancer. It's a breast cancer that does not express ER, PR, or HER2. So those are three of the very important markers that we look at in breast cancer that help us define our treatment schedule. So 20% of these triple-negative breast cancers are actually BRCA1, so there's a close association. BRCA-ness is a new coined term, which are triple-negative breast cancers in patients that don't have familial mutations, that don't have a family trait of BRCA, but yet there are DNA changes that make these tumors act like BRCA-positive cancers. So back to the basics again, just for a moment. I want to make sure everybody's on board here. I have a review of the receptors, ER, PR, and HER2, just so you understand them a bit. So the estrogen receptor in the breast cancer cell, estrogen's the key. This is the lock. The key fits into the lock, opens the lock, and the DNA will function. This allows the cell to grow, spread, and proliferate. Anti-estrogens, such as tamoxifen, look like estrogen, but they are the key that doesn't have the right grooves. It fits into the lock, but it won't open the door. And so these things will actually block the estrogen in your body from getting to the cancer cells. So the estrogen receptor negative breast cancers basically don't have any of these. There's no ER, there's no PR, there's no HER2, so how do we control their cell proliferation? We can't treat them with tamoxifen. There's another receptor you need to be aware of called HER2. Has a lot of information in the press. Basically, HER2 is a growth factor response. There's a growth factor in your blood that binds to this receptor and will send a positive signal into the DNA to activate the genes, and the cell divides and grows. The problem is that HER2 is always present, so there's never a negative HER2 cell. There always it's different variations of how positive that they are. So a HER2 positive breast cancer basically has too many copies of the DNA, making too many proteins and too many receptors. HER2 positive breast cancers are considered to be pretty virulent and tend to spread pretty quickly. On the other hand, we have an antibody to it called Herceptin, and so treatment of HER2 positive breast cancers has been revolutionized in the past few years. So here we are again with triple negative breast cancer. I have no receptors to go after, and all I have as a choice right now is chemotherapy. So we're stepping up the pace. Anybody not awake, please stand up. Moving on. So how do we treat triple negative breast cancer? Now we're getting into the meat of what we really do. So standard chemotherapy options that you may have heard about, adriamycin, Cytoxan, Taxol, etc. These chemotherapies do work in triple negative breast cancer, but maybe not quite as well. There are non-traditional chemotherapies that are being used now, the cisplatin, carboplatin, the platinum families, which are actually very beneficial in triple negative, as I will explain. And then most important for today, we're going to talk about targeted therapy. Very exciting new field developing. We need to find new targets other than the ER, PR, and HER2 to go after. So, some targeted therapy in triple negative breast cancer. First, we're going to talk about the PARP inhibitors. These are two of them that are currently in clinical trials, olaparib and viloparib, anti-EGF antibodies such as cetuximab, and androgen receptor inhibitors such as enzalutamide. I'm not going to go into detail about this one, but suffice it to say that triple negative breast cancers often still maintain production of an androgen receptor, and females have testosterone in their bodies. And so enzalutamide is actually like it's just like tamoxifen would be for the estrogen receptor. So it's a blocker of the testosterone receptor. And then finally, there's SRC inhibitors such as dasatinib. So we're going to go over the PARP inhibitors first. The next slide. Okay, so PARP inhibitors, basically, this is the name for it, adenosine diphosphate ribose polymerase. Basically what this enzyme does is it helps to make the A, I don't know if you remember in DNA, it's GATC, makes the A, helps it go back into the DNA. So PARP is an enzyme in the cells that help repair damage to the DNA. And the bright side is that it appears to be very active in BRCA-mutated cancer cells. So when the PARP is inhibited, the breakage in the DNA accumulates in the cell. Just like as when BRCA is mutated, when PARP is mutated or blocked, the breakage in the cell accumulates because the DNA cannot repair itself. The second line repair for cells is BRCA-related pathways. So again, when this is non-functional, then the cells can't repair the damaged DNA, and they become more sensitive to chemo, and they die. That's what we want. So, what does PARP do? Again, DNA damage, PARP goes in, fixes the DNA, helps to put in the A, it, cell survives. PARP inhibition, we're blocking the function of the protein, the DNA collapse, apoptosis, or cell death. Can everyone see this pointer okay?
Mm-hmm. Yes.
So, just briefly, mechanisms of DNA repair, including things that cause DNA problems, environmental factors, different physiology, chemotherapy, radiotherapy, and then some of the major pathways are listed here, but noting BRCA1 and 2 is one of them, base excision and repair, and PARP1 is noted here. So, there is an additive effect of BRCA mutation and PARP inhibition. So here you see all these different problems causing DNA damage, which happens in our cells on a daily basis. Normal cells repair themselves and they continue to live, and we're all happy. Second time, sometimes with the PARP inhibition, for example, we'll have DNA repair will be partially inhibited, but the cell will still be able to repair itself. Same thing here with the BRCA mutation. When you get to both, and you cover both repair mechanisms, the DNA can't really repair itself, and then we have cell death. So the additive effects of these different mutations and the medications can help to increase cell death. So PARP inhibition and BRCA1 and BRCA2 deficiency summary. Essentially, BRCA1 and 2 cells are deficient cells. They're markedly sensitive to the PARP inhibitors because they already have a mutation. They're also they're treated with the PARP inhibitor leads to marked decrease in the ability of the cell to repair its DNA. And also having both the PARP inhibition as well as an abnormality in the homologous repair, which is BRCA mutation, results in greater cell death. So now I'm going to go over some of the clinical trials with these PARP inhibitors that are actually going on currently. So there's a phase 2 trial of an oral PARP inhibitor. It's called Adelphi, and it's a BRCA deficient breast cancer patient. Basically, we're looking at the efficacy and the tolerability of these oral drugs. So it's a proof of concept trial, single-arm, international. What that means is that they're enrolling everyone, and everyone gets the medication. They're doing 2 different doses, 100 and 400. We're going to concentrate on this one because I'll give you a heads up. That's the one that worked. So we look at the patient characteristics, and most of them have either BRCA1 or BRCA2, and then more than half of them are triple-negative breast cancers. And then we look at the response rate. It's actually quite interesting. The overall response rate was 11 patients, or 41% of them, had a reduction in their tumor size. And this is ongoing. In other words, patients, as they continue to take it, appear to have continued shrinkage of their tumors. So a 41% response rate for a non-chemotherapy drug, just taking this pill every day that inhibits PARP, is pretty impressive. So the progression-free survival, which means how long does the patient live when she's taking this medication without the disease growing, seems to be ongoing, and as you can see, it's measured in, it's getting to years. So there's another one called BMN 673, also looking at, it's a PARP inhibitor. It's selective for tumor DNA repair. It's a phase 1 study, so they're still looking for the safety and dosages. They only had 18 patients, and 9 of them had triple-negative breast cancer. There was a 72% clinical benefit rate in patients with germ cell line BRCA breast cancer. So in other words, those 9 patients, with the 18 patients that had total breast cancer, 9 of them had triple-negative, 72% clinical benefit. And what that means is that these patients had either a complete response, a partial response, or stable disease. Let me go back. Nobody said, wow, that's really good. That's really good in breast cancer. So I just wanted to give you an example of a bunch of the different PARP inhibitors that are currently in clinical trial. There's a Pfizer drug that's very popular. There's a Merck drug. This one, BMN 673, also looks very promising. Adelphi, we're going to talk about in a minute. That's ABT from Abbott. Taking this down, you should buy the stocks. So PARP expression in response to neoadjuvant chemotherapy. So higher PARP expression is associated with higher complete responsive chemotherapy. So in other words, if your tumor has more PARP protein in it, it tends to respond better to chemo. And that was shown when they measured the PARP expression, the amount of PARP in the cells, and the complete response rate to chemotherapy. 26% had complete response versus 8, depending on the low versus high PARP expression. So So which chemotherapy should be used to combine with the PARP inhibition? So one of the chemos that are being looked at, particularly in triple-negative breast cancer, are cisplatin. So cisplatin is a drug that is not normally used for breast cancer. It's commonly used for ovarian cancer and other cancers, but it seems to be particularly sensitive in triple-negative breast cancers. So response to the neoadjuvant treatment, meaning treatment with chemotherapy prior to the patient having surgery. Sometimes patients present with a breast tumor that is too large to remove initially in surgery, so we'll shrink it down with chemotherapy and these medications, and that will help to perform a more efficient surgery. So this was presented in 2009, and these breast cancers have increased sensitivity to certain chemotherapies. There were 10 patients with breast cancer with known BRCA mutations. They were treated with just cisplatin, again, a non-traditional chemotherapy, and the cisplatin was given for 4 cycles. Chemo was followed by mastectomy, and they looked at the tumor tissue for residual cancer cells. 90% response rate. Ooh. The logical next step is to combine platinum chemo with a PARP inhibitor and triple-negative breast cancer mutations. Because we went through all this. The platinum seems particularly effective, the PARP inhibitors appear effective, and the BRCA already have mutations, so we should almost be able to cure this, right? Fortunately, that's not always the whole story. There appears to be obviously other mechanisms by which the cancer can evade these medications. In other words, there are other ways to repair the DNA, and there are other ways for them to escape. So just looking quickly at another trial using one of these PARP inhibitors, GEM, in combination with carbo, which is a sister drug to cisplatin. They're randomized patients to either the drug with the chemo or just the chemo alone. And the overall response rate is very impressive. The BS201 with the chemotherapy is 48% response rate, and only 16% in the chemotherapy itself. So that's, again, very promising. Nausea, vomiting, diarrhea, really no significant difference. So it's well tolerated. I'm going to go through one more trial about this. This is called the I-SPY-2 trial. Again, neoadjuvant, treating these patients with breast tumors prior to surgery. Lorazepam is also a potent inhibitor of PARP. This is one of many trials that are going to be coming out of this, but basically they took these breast cancers, they're HER2 negative, they're triple negatives, lorazepam plus carbo plus Taxol. Carbo is an atypical chemo, Taxol is very commonly used, and this is the PARP inhibitor. So this trial is still ongoing. It's going to be presented, probably some more of it at ASCO next month. But basically we can see that there's a clinical response rate, complete response rate for the combination, significantly better than the drug, the chemo alone. And this is particularly seen in the triple-negative breast cancer versus, say, the hormone, the estrogen receptor cancer, no major difference. And also here, in the HER2 negative cancers that are not triple-negative, also no major difference. So this is, again, very impressive. And looks like we're getting to the meat of the problem. So just to impress you, here's a list of current PARP inhibitor trials. So as you can see, we're actively working on this issue, and there's many, many drugs in the pipelines right now. So one other receptor you can go after in triple-negative breast cancer that's not traditionally gone after is something called the EGF receptor. So essentially, again, there's the concept of the receptor. It's on the outside of the cell. Something binds to the receptor, and something happens in terms of the cell growing and living. There's 2 ways to inhibit these. One way is to use an antibody on the outside. This is more like something like a Herceptin antibody, although it's not Herceptin. Or they can use what they call TK inhibitors, TKIs, and those are small molecules that you swallow, pills mostly, and can inhibit the cells that get into the cells and inhibit the response downstream. So, in triple-negative breast cancer, the overexpression is seen in 50% of cases of triple-negative breast cancer. So this is pretty impressive. There's a lot of these receptors out there, so it's a pretty good target. More EGF receptors are seen than in other types of breast cancer. So in ER-positive breast cancer, these receptors aren't seen. And these are 3 of the drugs that are out in clinical use right now. These are FDA approved for other cancer types, but are being looked at in breast cancer as well. So here's a clinical trial looking at the combination of one of these EGF receptor inhibitors and cisplatin. And again, you can see that the response rate, although not we're not curing anyone with this, is twice that of the chemotherapy alone. Actually, and I also want to point out that there's a large number with stable disease, which oftentimes when cancer is in more of advanced stage, if you can stabilize the disease and keep and maintain somebody's quality of life and the disease, you will actually be doing them an enormous service. So VEGF inhibitors, this is a big one. I just wanted to mention it just because most of my patients have heard of this, and if they haven't, then their grandmother has, and they come in with the newspaper articles and ask me if I can have this. So Avastin is bevacizumab. It's an anti-angiogenesis drug. It's quote-unquote starves the cells of blood and oxygen and nutrients. So it starves the cells. Basically, it's given intravenously. It's an antibody to the VEGF inhibitor, to the VEGF receptor. It blocks new blood vessel formation. So tumors, as they grow, need to recruit and make new blood vessels so that they can nourish themselves. If the blood vessels are not there, the tumor cannot grow, it dies. So decreased potential of cancer cells to spread and grow. So this sounds good. Let me just go back real quick. There are some side effects to this that are I'm going to go through in a second, but it's not the panacea that it seemed that it was going to be. There's some other, these are the small molecule inhibitors that you can take orally. These trials are ongoing. So the VEGF pathway, sort of like the EGFR pathway that we talked about before. We have a receptor, we have antibodies, we have small molecules that'll block down here. So as you can see, we're going at this at every single target possible. We're going outside the cell, we're going inside the cell, we're going after the DNA, and we're really analyzing and trying to understand the cancer at its core. So here's some other VEGF inhibitors, just so you can see how the large number, again, that are in trials right now. So looking at, just to show you a little information about bevacizumab, we did a neoadjuvant trial with Taxol and Carbo and bevacizumab. And again, these were done in triple-negative breast cancers, stage 2 to 3. So these are cancers that before surgery. They got chemo with Avastin, chemo 2 chemos, oral 2 chemos, and the Avastin. All the variations. So not to bore you with all the information from it, but the upside is that basically there was no additive effect with the Avastin and the Carbo together. This was a little disappointing, obviously, particularly for people who had stock in this company. The addition of Avastin increased the response in the breast, but not the lymph nodes. So that tells us that perhaps it does not help in all different types of tissues. And the risks of the bevacizumab may outweigh the benefits. These are healthy, curable patients that are taking a drug that can increase the risk of hypertension, strokes, internal bleeding, bruising, etc. You also have to stop this drug several weeks before surrounding surgery because of, again, the risk of bleeding. Because don't forget what it does. It inhibits blood vessel formation and cure, fixing itself. So carboplatin is increased response of tumor in the breast and the lymph nodes. So we saw a better benefit with the Carbo than we did with the bevacizumab, and they were not additive. So again, there were mixed results in the clinical trials. Some showed an increase in response rate to the chemotherapy initially, but no studies have been able to demonstrate an increase in overall survival, which is a very difficult endpoint to reach. But basically what happens is that we can show that it might shrink the tumor, but if we can't show that it causes or allows the patient to live longer, particularly at the price of this drug, it's not going to be approved. So right now it's a no-go for Avastin for breast cancer, but you never know. Something that might come out soon. So this is my last topic that I wanted to talk about. Everybody want to shake out? Ready? Okay. Molecular profiling. This is really exciting. I'm very, very excited about this. This is something that's probably going to become the standard of care in the future for all cancers. Right now, it's only the standard of care for a few cancers: lung, colorectal, melanoma, GIST, and some thyroid. There's a protocol of memorial sloan kettering in which we take this, we enroll patients with particular cancer subtypes, and we allow molecular characterizations for this. So what we do is there's something called IMPACT that I'm going to show you in a minute, and they take a large number of patients from each cancer type. And what's very exciting about this is because of a grant that we have, there's no limit to the number of breast patients that can be sent. So we can analyze almost all breast cancer patients with this, although it's preferably at this time for estrogen receptor positive breast cancer. So the primary endpoint here, and why this is so exciting, is not just to get these genotype results, in other words, what mutations do we have, but also to help find targeted agents that can go after each of these mutations. So basically, they take the patient's tumor, they break it up, they get the cancer, they run it through a sequencing machine. I'm going to just call this like a big black box, but it comes out with a genome expression, and it shows you normal expression of genes and abnormal mutations. And it can pinpoint mutations that patients have in innumerable numbers of genes. Right now we're studying 300 genes. So some examples of targeted therapy that are coming out of this, these are well known, obviously. HER2, trastuzumab, KRAS, which is another mutation in DNA and often found in cancers. We have specific antibodies to it. The GFR we talked about. This is another one that's very important in breast cancer, PIK3CA, which is we have inhibitors to that, and mTOR inhibitors as well. And the P10 from the Cowden syndrome that you heard about before, there are AKT inhibitors for this. So as we are noting these different genomic changes and mutations, and we're having the small molecules develop that will help to fight some of these problems in the DNA repair and function. So this is the current list of the 341 cancer genes that we're sequencing for. So all we need is a couple slides from your tissue, from a tumor, and we can sequence for all of these, and usually within a couple of weeks I'll get a report that'll tell me exactly what mutations the patient's tumors have. Now the problem is that we don't have, obviously, targeted agents for all of these tumors or mutations, but we do have a large number right now that are very exciting, and there's more in development. So in conclusion, the defects in DNA repair in BRCA-related tumors and triple-negative breast cancers provide a unique therapeutic target that's different than other targets that we've gone after before. PARP inhibition appears to make these tumors particularly susceptible and drives them towards cell death. Early clinical trials demonstrate promise with the anti-tumor activity of PARP inhibitors with very little toxicity. The optimal use of this class of agents is under intense investigation. The molecular profiling may revolutionize how we treat cancer and improve our outcomes. Targeted agents, as I discussed above, may not only be used in the advanced disease, but also in the adjuvant, which is after surgery preventative chemotherapy, or the neoadjuvant treatments. And also, very interestingly, they may play a role in the prevention of disease. We're currently looking at, there's an open trial right now at Memorial with PARP inhibitors, BRCA mutated patients with ovarian cancer. So you can prove stability of the patient's ovarian cancer and put a patient on the PARP inhibitor, which is an oral drug with little side effects, and actually we're showing excellent stability to the cancers. So this is a very exciting field. It could really change how we're treating cancers. As we often like to say, we're like to turn it into a chronic disease. I discuss it as a marathon, not a sprint. And these are very important molecules that may kind of change how we work in the future. So